So good morning. Everybody doing all right? Good night last night? Yeah, would you please stop yelling, Ed? There's a thing on your tables. The odd number tables, by the way, have antibiotic cream, just in case, with the hangover kit, by the way. Welcome to Austin. So I don't know that I'm actually going to have time to be able to do any presentation stuff, because with everyone ragging on me the past couple of days, I did a little bit of work this morning just to kind of figure out how I could re-rag on the previous speakers who ragged on me. And here's a challenge. I'm going to talk about we're all dressed up with someplace to go, but here's the challenge in this whole deal. So I don't know if you know, but I was going to rag on Brent Myers. Brent, he's not here. And it makes me sad. So as I'm watching television this morning, it's like, holy crap. Holy crap. So, fabulous physician, talented educator, apparently some of those habits. By the way, he made a big deal about that little half-inch going up and down that Land Rover too. But Brent, seriously, all kidding aside, brilliant physician, medical director. I don't know if you've seen the Wake County vehicles. Joseph, are you in here this morning, by the way? So, Wake County vehicles, very specific pattern. Brent is so wed to Wake County and his branding and labeling. I don't know if you know the secret behind Wake County Pride. You guys know that? There's a secret. If you ever visit Wake County EMS, talk with some of the paramedics. They love their vehicles. So then I said to myself, you know what? Dilly's going to do something to me this morning. I'll just kind of Google search him, and I'll come up with something. So if he does, I'll be, look at him, he's all nervous. He's got a heart rate like 160, doesn't he? Yeah, that's right. So I Google search Dilly, and I'm looking around, and it's like, okay. I start to look at some of the images, paramedic, looking through all this stuff, just kind of swinging through. Google search, yeah, look at him, he's like 180. Yeah, you're not sure what's coming up. So I just keep going through the Google search. This is disturbing to me. That's very disturbing. I don't know exactly what that is. And I gotta ask you, Chris, when I Google your name, hell of a lot of pictures of animals in beds. And I don't know, this is Chris Dilly, but there's deer, they are in bed. What's up with all that? So I said, crap, heck with him. Okay, Beck, I'll get even with you. So I Google search Eric Beck. And I figure out, shit, he's a bomber, for crying out loud. So you know what? I'm just not going to take any more time to Google search my colleagues. So that's it for the morning. All right. So we're all dressed up with someplace to go. So everybody knows the famous, I love this saying, everybody knows the famous sculpture by Michelangelo, the angel. And when he was asked, because it was such a brilliant sculpture, I asked him, they said, how did you do this? How did you come up with this? And what he said about the sculpture was, he said, I saw the angel in the marble and carved until I set him free. I saw the angel in the marble and I carved until I set him free. So if you think about where we are in EMS and think about yesterday, I mean, holy crap. We talked yesterday about something that really kind of doesn't exist in EMS yet, right? We talked about crafting the future. We talked about looking at who's doing things the best, trying to figure out, learn from our colleagues about what works, and carve in that marble to set the angel free. So I love this saying. It fits so many different things, but it really seems to fit where we are in EMS today. So I want to do a couple things. I want to look behind us just for a second, which is very scary, by the way. I want to look at where we were in EMS. You guys know this. I mean, some of you probably drove these damn things, for crying out loud. So you know that we stepped up to the plate in EMS as a profession, right? So when there were challenges in getting the busted and the ill in the streets, some kind of medical care, EMS said, hey, watch this. And EMS grew and developed in the 60s and the 70s. We grew and we said, hey, we can get care to patient sides. You don't have to put them in the horse and buggy and gallop your way to wherever you're going to go, to the family doctor's office, and put them in there bleeding and they'll fix them. We stepped up to the plate. I say we like I my partner's just going to go out and get one more piece of equipment for you. It's the battery for the defibrillator. So we stepped up to the plate, right? So we figured out, as a profession, we figured out how to take patient conditions. We figured out how to take public demand, because, public demand when emergency came out was like, I want that in my community. So we stepped up to that plate. We developed technology, and many of you in the room probably remember this technology. I mean, there was some cool stuff. You know exactly how greasy and slimy this thing got after running a code, right? There was like goo everywhere. Matter of fact, I don't know how we ever cleaned those things. You know that one of the things we did is we developed technology out there that was designed to hopefully take care of patients in the field so we could stabilize them, get them to the right level of care, definitive care, and move them on. So we got really good on the emergency care side. So good, as you've heard from other speakers, that the first board certification exam for EMS for physicians is coming up. We got so good that we've got our own peer-reviewed journal, Pre-Hospital Emergency Care. We got so good that we have funded research specifically for EMS, things like the immediate trial, the Racht trial. So we got really good at EMS. As a matter of fact, I'll do this. How many of you in your communities know that you've improved cardiac arrest survival rate in the past 2 years? You know it. Raise your hand. So there's a message there. So we know that we're doing pretty damn well on the emergency side, right? And for a while, we struggled with that. It's like, what do we do? But you know what? We're collectively getting our acts together there. We're looking at the things that matter in time-sensitive, time-critical conditions, and we've made some nice progress with that. So if you look around at what we're doing, and you look around at EMS systems, you know what? I think it's fair to say we need to celebrate what EMS today does in taking care of the unscheduled, acute illness and injury. We've done a heck of a nice job in that particular arena. So we're in this world of evidence-based EMS. I heard EBEMS for the first time a couple years ago at NMSP. It's like, what the hell is EBEMS? Evidence-based EMS. And when you first hear it, it's like, yeah, right, evidence, right? So we laugh, because it's like, well, what evidence? Well, you know what? There's a moderate amount of evidence out there that supports what we do in the field environment. We talked about the research targeting out-of-hospital care, significant advances, both cognitive and procedural approaches to managing patients in the field. I had a conference call discussion with a group about a week and a half or 2 weeks ago looking at intracranial ultrasound in the field. Intracranial ultrasound in the field. Now I'm going to use it with my kids and just see if there's anything up there. It's like, Harrison, come here. Let me see. Nope, still echo. So the concept that we can move technology in the field, there's technology today that you can take to a patient. You can take an ophthalmoscope to a patient. You can take an image, a picture of the retina. You can have that image sent to an ophthalmologist or an appropriate eye professional who can interpret that. You can look in ears. We can do all sorts of things. So our ability to move our skills or to move our diagnostic capabilities to the field and send information to people to make decisions has increased dramatically. We also have economic changes and a reimbursement focus. And I remember most of my career, whenever spreadsheets opened, it was like they closed automatically. I was a PowerPoint guy, not a spreadsheet guy. Who cares about the economics of healthcare? Really? What's a life worth? You ever said that? What's a life worth? I spent the first half of my career, hospital administrators' offices or city council meetings going, really? Let me ask you this, what's a life worth? Of course, now we've calculated that out, and it's like pocket change. So the concept of economics in healthcare was never something that clinicians messed with. As a matter of fact, if you talked about it, you were sleazy, dirty, right? I remember having to talk to patients about the cost of antihypertensive medications. We got a list. You ever get a list? And you had to talk to patients. And it was sleazy feeling. And then patients started getting bills. Then healthcare started to change. And then everything started to reform, so I know with my healthcare in general what's covered. I know when my son Brandon went and had a CT of his belly when I was traveling because he probably had too much poop in there, and his mom said, you know what, it's kind of bad, we better go to the emergency department. I know how much that poop cost. And that poop, by the way, that poop was verified by imaging and by laboratory. So we have laboratory imaging and exam verification of poop. So I felt how much that costs. Any clinician today that doesn't pay attention to costs is not an effective clinician moving forward. As hard as that is for many of us to say, well, you know what, are you kidding me? I'm not paying attention to that. Everybody else is. Jerry Overton, colleague of mine, who many of you well know since he's been out of prison. So Jerry was the executive director of the Richmond Ambulance Authority. And I remember having a discussion with him many years ago. Richmond, Virginia, 62 square miles, 60,000 911 calls at the time. And Jerry said, we were at 8:59, 90% of the time as a response time compliance. He said, Ed, I can save $1.2 million if we go to 9:59, 90% of the time. It's like, oh man, you're going to kill people. Bodies in the streets. Are you kidding me? Sacrilege. I said, a minute, Jerry, for crying out loud, the E stands for emergency. We got to get to the patient's side. $1.2 million in simulation, education, equipment, AEDs, crap. Made the decision a little bit harder. So all of a sudden, someone with the data, the expertise that says, this is what I'm paying to have ambulances available for 1 minute. You want to use it for 1 minute, or do you want to use it for defibrillators? So I said, hell with that, let's use it for a medical director vehicle. So we bumped it up a couple, and that worked out pretty well. So the economic changes are critical for all of us to pay attention to. We talked about EMS subspecialty, system design innovations. Systems are looking at new ways to deliver care. All of you are looking at new ways of delivering care. Healthcare systems, oh my goodness, are looking at new ways to deliver care. I mean, simple, innovative concepts. Jeff Beeson, have you guys had any freestanding emergency departments in Fort Worth? How's that working out for you? Perfect. So freestanding emergency departments, by the way, different from urgent care, freestanding EDs. So all of a sudden now, how many of you, by the way, just for our colleagues in MedStar, how many of you are struggling with freestanding EDs in your community? Apparently that community. So one of the challenges is healthcare systems are adopting the new kind of healthcare mantra and changing just like we are changing. EMS of impact on the healthcare system, I'm going to show you that. And then this, show me your stuff. Raise your hand if you're good. Let me rephrase that. Stop. Although I would point out, none of you quickly raised your hands, just as an aside, just saying. Raise your hand if you think your EMS system is good. Raise your hand. Keep it up if you think you're great. Okay, great. Okay, raise good again. Keep your hand up if you can prove it to me. All right, so a few of you, probably 50% of you. Healthcare now has to prove its worth, right? So there are certain chemotherapeutic drugs, as you know. Hey, Joseph, happy birthday. Good morning. You and Fred Flintstone have the same birthday, I think. If I'm not, can you whisper in his ear, happy birthday? The guy can't hear worth a crap at his age. So we have to prove chemotherapeutic drugs. There are chemotherapeutic drugs, agents, that can't be given to a patient until they're tested to see that that drug makes a difference. So whether they test the tumor cells in a dish and over into the test tubes, they test the drug. If the drug works, then you can get it. If the drug doesn't work, you know what? You don't get a shot at it because they're not going to pay for a drug that doesn't work. If I'm a surgeon, which would be the scariest thing on the planet, if I leave an instrument in your belly, so 4 years ago, if I left a hemostat in, be like, hey, Bob, do it again. 1, 2, 3, 4, 8. I swear we started with 9. I swear. Get a belly film. There it is. So 4 years ago when that happened, it'd be like, Mrs. Johnson, honey, I am so sorry. Listen, you were kind of a complex case, and while we were in there, one of the instruments was retained. So what we're going to do, you've got Blue Cross Blue Shield. They will pay for a reoperation. I've called anesthesia. It'll be a quick one, honey. We'll just sew you right back up. We'll get that retained instrument back where it belongs. And sorry for the extra couple days in the hospital and the infection you might get, the extra surgery and all the extra lab work, and of course, all the imaging. The good news is Blue Cross Blue Shield, they're on your side. They'll cover it. Today, what happens? Save your receipt. You were in there once, it's on you. So today, if I leave an instrument in someone's abdomen, you know what? The reoperation, the infection, everything associated with it, on the house, baby. Come on. That is a preventable problem. That transparency, and I'm going to show you that in a minute, that transparency is something that healthcare now promulgates to all of us. So guess what? We can know about certain characteristics of healthcare so we can make a decision. We can look at how they're doing. So transparency and accountability are a major shift in focus in healthcare. So I'm going to argue that EMS is pretty healthy today. And by healthy, I mean we're starting to ask the right questions. We are asking what makes a difference. That's extremely healthy. We're starting to ask how to measure it. That's extremely healthy. We're looking at how we integrate with the healthcare system. That's healthy. That's what internal medicine, ophthalmology, gastroenterology, that's what all of those other specialties ought to be doing it. And EMS, we're starting to do that, and we're paying attention to that. Healthcare overall, not so much. So healthcare overall is still kind of struggling to figure out exactly where it's going to live, right? Struggling to figure out what the operational components, the system's going to look like. Brent showed you this data yesterday. You know, our challenge is the healthcare system is the most costly in the world. There are new demands, a third, $750 billion, plus or minus a couple billion, of healthcare costs don't improve your health. That's pretty good news. So here, let's buy that. Sorry, it doesn't make a difference, but you know, at least we're buying it. So we've got those challenges. We've got the fact that we're going to see 5 to 10% of our populations, as Brent said yesterday, each year, and 11% to a half of those, you know what, they don't even require ambulance transportation to the emergency department. I think all of us would even bump that up even more. And if we had alternate non-emergency destinations, that number would be higher. And it's the you call, we haul thing. The challenge, again, as Brent showed us, is not that the bad stuff's getting worse. It's that the not so bad stuff is increasing in volume. So, as healthcare reform looks at a better way to manage this stuff and a better way to take care of patient populations, all of a sudden EMS gets inserted into the picture. And you know that. So we're trying to figure out where we landed in the picture. And yesterday you heard from several speakers very, very nicely that EMS fits into the picture in a variety of ways, but in particular to help navigate patients through the healthcare system. So along comes this thing, the triple aim. It says, you know what, let's make their experience better. Look, what do you want? You want me to be nice or save your life? Well, you know what? Both. I want you to save my life. I want you to be nice when you do it, and I want it to be effective, efficient, and as low a cost as possible without waste. So we used to joke about triple stuff. You know, you talk about stuff in EMS, get there fast, you know, all that stuff. It's like, here's the triple aim, pick two, because we can't do all three. Well, guess what? Can we do all three? The rest of healthcare is doing all three. So new healthcare has several components to it that impact us. Evidence-based approaches, prove it. Prove you make a difference. Integrated effort, focusing on the patient's health. It's got to be accessible. It's got to be easy to use. The patients have to have a nice experience. It's got to be cost-effective, transparent, accountable. And the culture of delivery has changed dramatically. So, you know what? Improving care and quality, I could put up 1,000 of these. These where healthcare system said, I gotta tell you, we're the Cleveland Clinic for crying out loud. It's costly to be the best. So Eric, Cleveland Clinic, which you're well familiar with, have they been successful in the triple aim? Absolutely. So the leaders in healthcare are improving the patient experience, are improving health of the patient population. They're doing it for lower costs. Shame on us if we don't do the same thing. So does that mean cut/burn? Absolutely not. Absolutely not. It means focus on doing what's right. And I won't bore you with that example. So there are these kinds of things. This is one of the newest journals in healthcare. Look at the title of it. Healthcare, the Journal of Delivery Science and Innovation. So there's now a peer-reviewed journal out there that essentially says it's not just what you do, it's how you do it. Because remember, my little hangnail example from yesterday, I could get a physician to look at my slightly increased red hangnail that I've had for 40 years. I could get a physician to look at it within an hour. I could do that. Any of you could. Matter of fact, if any of you have a swollen hair follicle, come ride with me. We'll get them both checked out. That can happen. Is that the right way to do it? No. You ever had this happen? Mrs. Johnson, we're going to run you over to St. Mary's. No, you're not. The last time I was there, I had surgery in my abdomen. It's like scars all over the place. What kind of surgery? In my belly. I am not going back there. Well, your surgeon, I am not going back there. So you take them to the emergency department. What do you got? Well, Mrs. Johnson says she got some belly pain, had a bunch of surgery on it. Where'd she have her surgery? Oh, she's over at St. Paul's. Why'd you bring her here? She wanted to come here. We don't have any of her records, right? Good news, though. Good news. Let's just scan her belly. Let's draw a bunch of blood. Let's see if we can figure out what happened to her. Mrs. Johnson, don't tell us about the surgery. See if we can figure it out with a bunch of tests. Right? So you scan, right? That's what we do. You scan, look for missing parts, and say, aha, look at that, gallbladder. So the current system will take care of patients, but it doesn't do it efficiently and effectively. Enter EMS into the arena. Tuberculosis is crazy. So I'll tell you, it's beautiful for weight loss. So if you look at where we are in healthcare, I hope this little cool slide works. This slide sometimes works, sometimes doesn't. This is how we're aligned now, right? So we're aligned in healthcare where there's the emergency side, the 911, the first response, the ambulance transport piece. That's silo one. Silo two is the hospital side, the facility side, the ED, the hospital inpatient admission, then post-acute care. We don't really care that much about the ED, hospital, and post-acute care. If we're looking at continuity of care, do we save more lives? Do you think? Do you think? Do we save more lives? Do we pull more people off the big escalator, right? They're on the escalator, they're going one way or the other, whatever they've done. So do we pull more of them off with ambulance transport or with getting to their side quickly with the right tools? Raise your hand if you think it's getting to their side quickly with the right tools. Raise your hand if it's the ambulance transport piece. So therein lies one of our challenges, right? One of our challenges is everyone in the room knows if you're going to die in front of me, right? You're going to die because you go into cardiac arrest, you need to be defibrillated, you're hemorrhaging, you need to stop the hemorrhage, you've got an airway obstruction, you need to get the airway unobstructed. There are things you're going to die from. And in general, with a little defibrillator in the hallway, we can take care of just about anything with our hands, right? And the defibrillator, pretty quickly, seconds. So isn't it true that with healthcare, did it work? Crap. One hit too. So isn't this who we are becoming? Are we now becoming this component, the 911, the first response, the Annie, are you okay? Ma'am, I'm going to tell you what to do. The ambulance is on the way. The fire department's on the way. I want you to put the baby on your, right? So pre-arrival instructions, airway occlusion. So maybe the pull them off the escalator piece is that time-dependent, because it is time-dependent side. And the healthcare system side, the ED, EMS, hospital care, and post-acute care, maybe that's the new norm. So healthcare, mobile integrated healthcare, becomes this piece here, because maybe not every patient gets taken to the emergency department. Maybe, we talked yesterday, most of my career, I fought, when I was here as the Austin Travis County EMS Medical Director, I fought transporting patients, students. That would be all those people that you try and hit when you're driving through the camp. They're like 8 points each. I mean, I could have made like 68 points coming. So I fought all my career. The University of Texas said, if you have a student and it's non-acute and it's during the time that student health is open, bring them to student health. I said, it's not good patient care. We're not going to do that. Not going to happen. What would I say today? Absolutely. You know what? Get the curb fixed so we can back up, put an awning, and we'll bring them to you. So healthcare and the alignment of healthcare is changing dramatically. These are some of the pressures. 50% of the healthcare costs are attributed to 5% of the population. Matter of fact, we could have an exercise in here, and you could probably give me the names of those individuals in your community that make up the 5%, because you see them. Right now, every one of you has an image in your head of a face that lives in that 5% population, because we see them so often. Many of you have the exact address of the 5% of that population. And you know, so when the tones go off and it says Medic 6 Priority 2, 110 East Live Oak, you know exactly where you're going. You're going to the top 5%. That's the category of patients that healthcare is really trying to manage in a better way. There's that increasing pressure to improve care, and then these things. Do you know your health insurance plan is rated on how well you can access the plan, how the plan and its healthcare providers take care of you? It's called a HEDIS score, and there are star scores. So health plans are now rated based on what your experience is. Health plans are rated on whether, let's say if you're a diabetic, you have to have a hemoglobin A1C drawn every year. And if you don't, and that clock turns on December 31st to January the 1st, and you haven't done hemoglobin A1C, the health plan takes a hit. Do you think EMS could find some of those tough patients if the health plan says, hey, I got some hemoglobin A1Cs you got to draw before midnight on December 31st because it's good for their diabetes? Do you think you could find them? Because I'll tell you what, the health plan will pay you to do it. They did for us in South Florida when they freaked out appropriately that those patients, they couldn't find them, they couldn't get them into doctor's offices, they couldn't get their blood drawn. But the EMS world is to say, by George, we'll find you. We will find you. So HEDIS scores are an important part of healthcare reform. We've talked about some of the other influx of patients and the triple aim. So next week, right? The health exchanges kick in, right? So what day is the first? Monday? Tuesday-ish? Monday. Guess what? Monday. Everyone can have insurance. Monday. What a Charlie Foxtrot that's going to be for a while, right? So the concept here is that there's more payment for patients who enroll in healthcare exchanges, but it's going to take a while to figure it out. And by the way, the plans want us to do an effective, efficient, triple aim-like job managing them. So, what's all that mean? The next chapter of the profession historically known as simply EMS is mobile integrated healthcare. And we've talked about it. We talked about it all day yesterday, and we're going to talk about it today. This is kind of mobile integrated healthcare in the olden days, right? Where Dixie and Kell and Roy, everybody kind of communicated to figure out what to do with the patient. So when you had the bad plane crash, you had Rampart and Squad 51 talking about the dose of epi that went into the patient that was blown up from the plane. Now, there were some challenges with that, but the two were communicating to figure out what to manage with the patient care. So now, here we are again. Did a good job with the EMS. So here we are again. Now we're all dressed up, and now we have a new place to go, if we choose to. And by the way, we don't have to, because others will if we don't. But now we're all dressed up, and the healthcare system's saying, hey, could you help us? Could you be a 910 and a 912 as well as a 911? Why, absolutely we could. So if EMS now has a seat at the healthcare table, if we are now part of the healthcare system, what are we going to do? Are we going to sit back? Big storms are brewing. I'm glad we didn't go on that cruise thing with your whack job friend Noah. right? So we're in the storm. We are there. It's changing. We have a choice. And we have a choice to say, it's really going to suck for you guys in healthcare. Let us know what we can do. Feel free to give us a call at 911 if we can help you in any way. And that's what many systems will do. Or we can say, you know what? We have a skill set. We have some expertise we think can help. So what do we need to do to be successful? Here's a quick question. How many of you in this room believe, in your heart, believe that mobile integrated healthcare is a major component of our professional future? Raise your hand if you believe that. Almost the entire room. Raise your hand if you know exactly what it is. Crap. So we have a little challenge here, don't we? So you just told me you believe this is a major part of our future, but not sure exactly what it is and where you're going. And by the way, I would have voted the exact same way. Eric, same way. We're trolling through the same challenges. So if that's the case, what are some of the things that help us define space and move us forward? So one is, I think as our colleagues have nicely shown us, the MedStar experience, the experience in community paramedicine in programs around the country. As you know, MedStar changed from MedStar EMS to MedStar Mobile Healthcare. So this concept of changing in the environment. And one of the things that's important to remember is just like Rampart, Squad 51, just like the fact that if I'm stabbed in the spleen and I go over to Brackenridge, it's not just going to be the emergency physician that sees me and everybody else hopefully stands outside the doors. I'm getting surgeons, I'm getting nurses, I'm getting labs, I'm getting all sorts, probably getting a chaplain. I'm getting all sorts of stuff because together they do a better job of putting Humpty back together again. So true with mobile integrated health. So the community paramedicine piece, the paramedic component of that is one of the whole system. We have to be very careful with EMS. We talked about this yesterday. When we say EMS to healthcare plans, they think, they see uniforms, they see badges, they see radios, they see us rappelling into the nursing home from the helicopter, they smell Jet A with the sick, weak, and dizzy. They don't see mobile healthcare because that's not something they're familiar with. So we have to be careful about that. How many of you in your communities have had healthcare systems or freestanding clinics or doctors' offices say, can you do me a favor? Can you not send fire first response? Because when you do, and all the patients think the building's burning, it scares everybody, right? So it's a different perception of healthcare. The end game changes. And the end game changes based on something very important. So we talked about yesterday, almost anyone can do mobile integrated healthcare the way there are parameters. You know what? Did you get the bargain batteries here? Hello. So the mobile integrated healthcare in its infancy really needs guidance and data. So what will make us successful? I'm going to show you something. So the other players in healthcare, because we want to sit at that table, right? We want to sit with healthcare. We have something to contribute to healthcare. We are indeed 910, 912 on the healthcare side. The other players have a perspective that we need to understand. This morning, I just went in to Healthcare Hospital Compare, and I went in and thought, you know what? If I needed to go to the hospital, let me put my zip code in, and let me just see how the 3 hospitals that are closest to me belly up. How do they compare? You can do this. Any one of us can do this. I go through this. I want you to ask yourself, what if your community would look at you and your data and say, hey, Sally, what do you want? 911, 912, 916 looks pretty good, but I'll tell you what, 917 has a pretty low mortality. Call that. Crazy, isn't it? Crazy, isn't it? Not so much. Because healthcare, remember the triple aim, wants to make sure that everybody, doctors, therapists, home health, hospitals, are walking the walk. So let's have a look. This is my neighborhood. These are my 3 hospital choices. And in fairness, one of them just opened up, but I left that in there. So this is what I would see. And if you look at the first page, hospital, Good Lord. It must have been Brent wearing these things out yesterday. So if you look at watch how I'm going to do this transition, you're not even going to know it. So if you look at the first, see, they're all wrapped here, which is a problem. So if you look at the first page of Hospital Compare, and you look at, no, seriously, they're not noticing anything. Sit down. You're making a big deal out of this. So if you look at the first, woo, there we go. Trailers for, so if you look at the first page of Hospital Compare, look what the first data elements are. Matter of fact, I didn't know this until recently. So the first thing you see in Hospital Compare, the first thing they tell, yeah, I'm struggling with this little thing here. The first thing they see is, hey, you know what? What kind of a hospital is it? Do they provide emergency services? And why the hell is it important that they're able to receive lab results electronically, or that they're able to track patients' lab results, tests, and referrals electronically? The first thing you see. So the government, CMS, says to the public, says to me and my neighbors, one of the things you might be interested in is whether your hospital can exchange information with someone else. You see how this is kind of coming together here? I wouldn't have even thought about that. Government says, you need to start thinking about that. That's important. Things like this. So heart attack data. So I can compare with the hospitals in my hood that I would go to. I can compare, as you know, PCI within 90 minutes of arrival. By the way, you guys know this data. We've done a tremendous job in emergency services, emergency cardiology, and taking this number and shrinking it substantially. So this has a direct impact on whether I'm going to be a cardiac cripple or not. I want to see what those numbers are. There are things like pneumonia, the most appropriate antibiotic, initial choice. So you can look at how the clinicians chose your antibiotic. You can look at things like the average amount of time patients spent in the emergency department before they were seen by a healthcare professional. By the way, the y-axis is mislabeled. It says hours. That should be days. I think it's a little mislabel in there. Why the hell do they have that on there? Who gives a hoot? Who gives a hoot? What's the biggest complaint we get in EMS? Bar none. Bar none, the biggest complaint we get. What took you so long, right? How long did I have to sit in the emergency department? Improving patient experience, improving welfare. So guess what? There's a parallel in that regard. So I want to know things like how are we readmitted? What's the death rate? No different, no different. Hey, it's not available. And by the way, CMS, and I don't know why, but CMS has blocked several of these metrics out for the past several months. Death rate for heart failure patients, no different, no different, no different, no different. So you look at those kinds of things. You look at things like urinary tract infection. You look at things like percutaneous coronary intervention. So now all of a sudden I can go on there, and the American College of Cardiology says this is why you need to look at this. This is why this is important. Hey, EMS, that's why these metrics are important, because it impacts patient morbidity and mortality. You can look at things like the outpatient CT scan use. You can look at how they're being used. So are you hitting the double whammy? Are you getting more imaging? Are you glowing in the dark versus just what you should get? So you see the trend here. You can look at this kind of stuff, patients who reported that their nurses always communicated well. 75% at Seton, 79% at St. David's South. Why is that important? Are you kidding me? Why is that important? Really? Does it matter to you if your clinicians communicate well with you? You ever been sick? You ever been on the receiving end of healthcare? Which, by the way, the platinum rule, always a provider, never a consumer. Although, where's our colleague who enjoyed a little endoscopy the other day? So, why is that important? How many of you have been in the back of the ambulance on an emergency department stretcher or been in an OR before? Raise your hand. Did it matter to you if the people were nice? Were you kind of freaked out and scared, even though you knew healthcare? Yeah. I remember, I'll ramble for a second, when I fractured my shoulder, I had to have surgery, and I had surgery about 2 miles north of here. And I was chicken shit. I absolutely didn't want to be in there. So at 5 o'clock in the morning, I'm over, I'm getting prepped. You know, I've gone through all my stuff. I'm NPO just in case. You always love that from the anesthesiologist. You know what, I think we'll do local here, but why don't we make you NPO just in case? You know, you're checking how solid your front teeth are for that NPO just in case. So as the nurse is scrubbing my shoulder, I'm sure my heart rate was like 120. My blood pressure was probably about 290 over 180. She said, "Are you nervous?" I said, "Yeah, a little bit." She said, "Why are you nervous?" I said, I don't know. This is, you know how it is with those of us in healthcare. You know, I just kind of picture everybody wheeling me out and the anesthesiologist going, "Well, shit, why? What did we do with the alarm, for crying out loud?" You know, it's like, what is that noise? I don't know, alarm silence. So I'm so nervous. She's scrubbing my shoulder, and a friend of mine was going to do my anesthesia, and she got called actually to this hospital right over here and couldn't do it. She said, "But that's okay. One of my colleagues is going to do it. He's outstanding. He's going to do regional block. I think you're going to love him." His name was LD. So as the nurse is scrubbing my shoulder with my little tachycardic hypertensive self, she says, "Do you know LD?" And I said, "No." She's scrubbing away, and she says, "You know what LD stands for?" I said, "No." She goes, "Lethal dose." It's like, crap! Are you kidding or not? I mean, is that like one of those nurse things? Are you kidding? So patient experience does make a difference. It makes a huge difference in how we navigate through healthcare. So healthcare systems are measuring that. Healthcare systems are measuring perception, and as a matter of fact, starting next year, if you go to a healthcare system and the perception, the patient satisfaction, experience, quality scores are low, that particular facility now takes a hit. Thank goodness that hasn't hit EMS, huh? Hey, if you're a jerk, you get half of what we were originally going to pay you for. So healthcare is moving in that direction. We want to be a part of healthcare, right? So is it time for us to move in that direction? I know you can't see this, but this is a spreadsheet of the readmission data for 2013 for this particular year. These are those hospitals that surround this community. So you can look at the data that shows you who is penalized in this community for readmitting patients within a 30-day time period. You can look at the data. Everything is very transparent, and you can now make decisions about that. Hospitals love this, right, Jennifer? Hospitals love this. CEOs in particular of hospitals love to see that they've got a little readmission penalty because it gives them a project. It gives them something to rally behind, something to work on, something to chop people in the carotids with. So this data changes behavior. The data from HEDIS scores changes behavior. The fact that data on leaving surgical instruments and belly is there changes behavior. The fact that Foley's come out in a hospital quickly changes our practice because the data say if it's there and it's high, guess what? We're not going to pay you for that. So what's that mean for us? What do we need to do to be successful? Here we are in EMS. We've been clipping along pretty well. Response times, I can tell you in every single one of our communities across the country, I can tell you what our response time is. I can probably tell you, I'm guessing, we probably know it to the millisecond. We know that stuff like the back of our hand. And here's the reality. Does it make a huge difference? Is that what we're looking at? Hey, your anesthesiologist got up in the morning, got in his car, drove down 183, got to the hospital, had some coffee, got dressed in his scrubs, got into your case at exactly 8 o'clock. Exactly what we expect him to do. Now, he intubated your esophagus, you vomited, you aspirated, you got infected, you were on a ventilator for a month and a half, you went to an LTAC, and now you're neurologically impaired. But I'll tell you what, 8 sharp, in scrubs, ready to roll. So the 8:59, 9:59 response intervals, it was a good starting point, but it's not where we need to be. All right, Joseph, sorry to do this to you again. So Wake County EMS, one of the most respected EMS systems on the planet. I asked Joseph in a meeting yesterday, I said, Joseph, what are your response time requirements? And he went, well, I mean, we have some, I think, one of the most respected EMS systems in the country. Has some response intervals, I think, somewhere in there. The message is, while we may pay a little attention to response intervals, it's time to pay big time attention to what makes a difference. Because a cardiac arrest patient doesn't give a shit how long it took you to get there. They really care about neurologically intact survival. And I'll tell you right now, things like pain relief, things like improving respiratory scores, that's what our patients like. So if we want to play in healthcare, we got to walk the walk. We have to say, look at us. We can make patients better as well. So I asked you, do you think mobile integrated healthcare is a major part of our professional future? And almost everyone in the room said, absolutely it is. So what do we need to do to be successful? This is a fascinating guy. Anybody know who this guy is? Dr. John Holcomb, had an extraordinarily successful military career, trauma surgeon. He's now director of trauma surgery in Houston. He and I were having a discussion. We were speaking at a conference in Arkansas together, and we were having a discussion at dinner. And I just made the comment, I said, you know, John, it's kind of cool. In my career, you see so many military interventions being adopted in the civilian world. So tourniquets, our management of hypovolemic trauma, we're doing things different. Spinal movement restriction, rapid extrication, all the things that we learned from the battlefield, we've actually adopted in EMS a lot more rapidly than historically we have. And I said, so why is that, John? Why did all of a sudden we adopt this stuff so rapidly? And he says, quite simply, it was a huge investment. I said, good, that helps me a ton. Thank you. A huge investment in these recent conflicts, collecting, analyzing, and managing data. He said, they look at data upside, downside, all over the place on the battlefield so that they can make decisions about managing those soldiers who are in combat, who are injured and going through their processes. So even the military side, our adoption of new things relies extraordinarily heavily on data. I'm going to close with a story. I'm going to close with a story about how powerful data can be in an EMS system. So this is, anybody know where this is, by the way? Quiz. See if anybody gets it right. Buy you a cup of coffee if you get it right. Right, it's not. So this is Evansville, Indiana. So Evansville, Indiana did an interesting thing with their data. And I want to show you how powerful data analysis could be. How many of you have heard of RAPS, the Rapid Acute Physiology Score? So I had not really paid much attention to RAPS. It was one of those things, it's like, you know, my son pays attention to RAPS. I don't know what the hell that is. But I didn't pay much attention to it. So it's a physiologic scoring system. It was modeled after the Apache scoring system for ICUs. It was developed to basically try and score patients who were in a transport environment, so who are in the EMS environment with the tools and the data we had available in EMS. It's pulse, it's blood pressure, it's respiratory rate, and a Glasgow Coma score. And the scoring is 0, which is normal, all the way up to 16. Beeson's of 15 this morning. So it was this scoring system to be able to say, your RAPS is X. And by the way, all of us can get this pretty much, right? That's a pretty easy data set to get. So what Rhee and his colleagues identified was, in their paper, which I just showed you before, there was this relationship between the RAPS score and mortality or survival. So the lower your RAPS score was, the higher your survival was. That's like, well, that's pretty cool. Now, it's not linear, but certainly there's this relationship between this scoring method and your survival. So one of the things we did a few years ago was took RAPS data and said, I wonder what that looks like in our patient population with the data that we have. So Scott Bourne, one of my colleagues, spent a significant amount of time looking at a couple years of data, 750,000 patients, and found, well, lo and frickin' behold, look at that. So emergent return, medication administration, airway, medic deemed critical, and vascular access all seem to kind of climb until the dead bodies. You can see where the dead bodies are right there. They all seem to kind of climb, albeit their slope and distribution is a little bit different, but they all seem to climb with changing RAPs. So if you look at the data that he looked at, bottom line is about 270,000 patients, this is what he found. So what they found was if you look at I RAPs as the initial RAPs, E RAPs as the ending RAPs. So if this little scoring thing is somehow associated with survival, there are a couple interesting components to this data. One is, you know what, if anybody ever says to you, you guys don't do squat making people better, this is the kind of data that you can say, well, here's squat, here's how the patient started in squat, and here's what we ended up doing to them with squat. So I would beg to differ with you. We do make a difference in physiologic scoring, in initial and ending RAPs. And then you see this interesting trend. Well, holy crud. Took us less than 8 minutes to get there. We made them better. It took us more than 13 minutes to get there. Still made them better. That's kind of intriguing. I wonder what that means. So they took this data because Evansville, Indiana said, just like Jerry Overton, gotta cut costs, gotta cut costs. You know what, we can't, they're gonna have to lay people off, cut the quality. I don't know what they said because I wasn't there, but it was one of those elected official kind of things, you know, whack, whack, we gotta do parks, we gotta do potholes, you can't do this. So what they decided to do in October of '09 is decrease unit hours. They decided they were gonna lengthen response intervals and follow RAPs, their data. RAPs being this ongoing monitoring of the health of the patients they transported. And what did they find? If you look at the drill down, remember it started in October of '09, a couple things are apparent. One is, if you look at the initial RAPs, no change in the initial RAPs, meaning by the time the medics got there, these weren't sicker patients, right? So at least in a response interval change of almost 3 minutes, and in Jerry Overton world, I mean, that's a lot of cool medical director vehicles. So at least in that time period, there was no change in the initial. And then if you look at the ending RAPs, well, holy gamoly, no change in ending RAPs. So taking that data with all of the hospitals, all the chief medical officers of those hospitals, the medical director of EMS, the clinical leadership in EMS, the mayor, the entire community saying, we're gonna take longer to get there. It's gonna kind of suck, but we're keeping an eye on things. Taking all that data and plotting it out, this is what they found. So if you look at response time versus RAPs, the response time climbs significantly in that time period, and the initial patient RAPs, these are the 3 different priorities, didn't change over time, nor did ending RAPs. So the message to that community, if you want to talk about power of data, the power of data there said if we look at our numbers, if we pay attention, and by the way, one standard deviation of that data and woo, stop signs go up, we're going to stop. We're going to go back to a different response interval. So all of a sudden, the data was a tool to provide some security to the community to say, we're going to change response intervals, but we're keeping our eye on those response intervals. There's this too, because remember, it's how you slice data, and I'm struck by what Chris showed us yesterday on the new analytics piece. If you look at, you can find a period of time in your data where you go, holy crap. I'll tell you what, our cardiac arrest survival on Thursday sucked, right? So you have to be very careful because this is the cardiac arrest control chart for survival in that patient population. While you see it slowly increasing, you know, you look at a particular interval there, you could go, oh my goodness gracious. So analyzing that data as clinically appropriate becomes very, very important. So as we move into mobile integrated healthcare, if we want to play, if we want to be part of that data, we have to do stuff like this. We have to be able to say, if you're treated by us, your readmission percentage rate is 10.9%. Or your average hospitalizations per chronic conditions is as shown. Data that we've historically not looked at in EMS. Data that comes from hospitals, healthcare systems, and helps us make better decisions. But I'll promise you, am I right, Eric? I promise you, when we sit and we talk with folks about what kind of a role we can play in the healthcare infrastructure, when we show this and we look at a 30-day readmission rate that's dramatically lower than the spreadsheet that I showed you a minute ago, their little ears go up like dogs. Woo! Really? Woo! because it's a potential solution to a healthcare challenge we all face. So data helps us there as well. I hope what I've done in kind of a short period of time is set the stage for where we could go, because I think it's a very, very neat place to go. We have to do it with data. We got to do it with eyes wide open. We have to come to the table not just saying we're cool, we're good. We have to say, look how good we are. You decide if we're able to do what we say we can do. So my little Michelangelo thing, you know what? I looked at the marble and I carved till I set the angel free. So we see some marble, and there's some chips in there right now, and there are a bunch of folks carving. There are a bunch of folks saying, I know that EMS can do this. I know we can make a difference in our community. People aren't listening to us necessarily yet, but I know, keep carving, because the more we carve, the more we do it together, the better opportunity we have. And this, which actually could truly be the slide of my life, I mean, unfortunately, this is one of those things that's a wake-up call for us. A year from now, if we collectively as a profession don't pay attention to this, we won't need to, because others will be taking care of business and taking care of the stuff that you all told me at the beginning of this talk was one of the biggest future changes of this profession. So it's a very cool time. We need to manage our way in by data. When we manage our way in by data, and when you look at your data, as I think everyone in the room knows, you'll be pleasantly surprised in many circumstances, scared to frickin' death in others. But either way, you can take that data and morph that practice of medicine so it appropriately reflects what your community needs. So with that, I really appreciate an opportunity, as always, Chris and you guys, to spend a little time with you this morning. I hope that kind of added some perspective to my much smarter colleagues over the past couple of days that know what they're doing. And by the way, for the record, it's a full inch that damn thing goes up and down according to the owner's manual. So thank you very, very much.